You're listening to the 40 Fit Radio podcast, dedicated to the 40-plus community. Join us as we discuss the truth about fitness and health using science, reason, and the experiences of our host and content experts. Welcome to the 40 Fit Nation. Hey, welcome back to 40 Fit Radio and welcome back to the 40 Fit Nation. I am honored to have Coach Trent in the house this morning.
I feel very honored.
Yes.
Here.
You know, and I'm honoring you.
Yes.
And you know what I mean by honoring, don't you?
What do you mean?
Well, it's like the dog.
Are you like paying homage to me?
No, it's kind of like what were you saying earlier about Zizou, that he honors the other dog by humping him?
Yeah. Well, my little terrier mix. Yeah. He's
he's a cow dog.
He frequently he's half cow dog.
Yeah,
he's half Australian Shepherd,
cow dog,
half
Zizou,
Yorkie,
the cow dog, like a 1950s old Western. You know, I could see him with the little hat and a little silver pistol and belt.
Hey man, he's already got he's pushed a bull that was about 50 times his body weight.
He pushed Sonny
already
around. Yeah. Well, man, no, I'm honored to have Coach Trent back in the house. He's been gone for a week on a Smoky Mountains vacation.
Yeah.
And just getting out in nature and enjoying himself. And that's good. And so we are back. And today we are going to talk about total joint replacements and some training guidelines and general information regarding what to kind of do. And I say kind of because it just matters when you've had a total joint replacement. So we're mostly going to be talking about the shoulder, the hip, and the knee, with most of our time spent on the hip and the knee because those are the two big joints where the highest prevalence is in regards to the population and those who have total knee replacements or total hip replacements.
Yeah.
Or total joint replacements, you would say.
It's interesting. I don't know. I can think of a lot of people offhand that have had hip replacements or knee replacements. I haven't heard of that many people that have had a shoulder replacement, like shoulder surgeries, but not replacements.
Well, we call all these surgeries now joint arthroplasties because plasty meaning redoing, reworking, changing, arth meaning joint in Latin, and then total because we do the whole thing.
Yeah.
We do the whole joint most of the time. Now there's hemiarthroplasties too, where we do a unicompartmental where it's one side of the knee or the other. We don't do that in the hip. Generally, we replace both parts in the hip. But we'll talk about that. We'll get into more specifics here in just a second. But yes, total shoulders are less prevalent in the population right now, but it's on the rise.
Yeah.
It's definitely on the rise in regards to the number of people that have it performed on an annual basis. It continues to rise, continues to climb year by year. So today we're going to talk about the three most common procedures, like we said, the total shoulder, the total hip, and the total knee. Now, 9 times out of 10, the reason why someone has a joint replacement devoid of some massive trauma or something like that is due to osteoarthritis, which basically means arthritis in the joint. What happens is the cartilage deteriorates over time, and the cartilage is very avascular.
Right.
So it doesn't have a lot of blood supply. So number one, you don't feel, it has very little nerve supply too. So number 1 and 2, you don't feel it. And number 2, when it does get damaged, it doesn't heal very well.
Yeah.
And so that means that by the time some pretty significant damage is done, you may have had some achiness and a little soreness every now and then. But sometimes by the time the damage is done, you've got a pretty nice crater in your articular cartilage, and now you've got some bone on bone, and that really hurts because the subchondral bone, the bone underneath the cartilage, subchondral, is what starts to produce pain, and that's where you go, oh man, that hurts.
Yeah, we talked about that a little bit in the training with bad knees episode. Yep. Yeah, if you're feeling that, that's because you've got to wear through that cartilage essentially before you start to feel sensation in that in the bone on bone connection. Right.
I kind of get generally 3 or 4 questions from either patients, friends, family members, clients who know that you and I are strength coaches in the strength world because of our reputation, and they'll either call me or email me or see me in person and want a consult or something like that. And the 3 or 4 questions I get most commonly are, number 1, should I get a total joint replacement? Here's my activity level. Here's what I want to do. I want to be active. I'm involved in some type of fitness, whether it be running, cycling, swimming, barbell lifting, CrossFit, whatever it is. They want to know, can I do these things still after I have a joint replacement? Or am I going to basically be walking my dog in some senior center and I'm 45 years old?
Right, right.
Second question I get is, if I do have a replacement, which type should I get? What's the best for my use and purpose after the joint replacement? For the quality of lifestyle that I want to have, the things I want to do, which replacement would be best for me afterwards?
Yeah.
The third question I get is, what are my limitations? What things can I just not do anymore because I have a total joint replacement? And then the last question I get, and I get this less seldomly, but I think it's a question that everybody should be asking. I would be asking whenever I buy something or purchase something for my home, my car, the ranch, the gym, whatever. I kind of want to know, what's the life and quantity of use for that product or service that I'm buying long term.
Yeah.
How long is this thing going to last?
Exactly, because they don't last forever.
No.
They last forever.
And that's kind of been the general rule of thumb for surgeons. Orthopedists are the ones that generally do this surgery in regards to whether or not they're going to select a client to have this surgery performed. They look at the client's activity level. Well, first they look at the client's genetics and health. Then they look at the severity of the problem. Then they look at the age of the individual and the activity level that's going to be required post joint replacement, after the joint replacement. What do they want to go to?
Yeah.
And so in the past, it has been anyone really under 60 years old was kind of recommended, and maybe even closer to 65 or 70, were kind of recommended to put off a total joint replacement for as long as you can, because here's the deal. If you have one done, you only want to have it done once in your lifetime.
That's right. Yeah. Do you want to be 80 years old?
Do you want to be that guy
and on the operating table again?
Right. Who needs another joint replacement.
Yeah.
So, there's some concern there. That has become less of an issue as technologies have changed, as the quality of implants have changed, the purchasing of the implant into the bone and how well the interfaces are. So that has become less of an issue. And I see more and more clients in their mid to late 50s. I've got several 40-year-old clients that have had total joint replacements. Now, those guys are most likely in their 40s and 50s, and even in their 60s, they may have another joint replacement before the end of their life.
Yeah.
They'll have a revision done, basically. The problem with the revision is that you're dipping back into the bone stock resource for a second time to try to make something fit after you've already kind of cut things up. And you've and you don't know what's going to happen when you take off the old implant.
Yeah. So. Well, and you think about, like, just generally speaking, going under the knife at age 55, that's a different event than when you're age 75 or 80. It's just a lot harder to recover from.
Right. And there's a lot of scar tissue and other issues there. You always want a virgin joint when you're working on things versus having to go in and fix someone else's stuff or fix something that you fixed in the past.
Yeah. So what's the can you give any like ballparks for like how long joint replacements are lasting these days?
Most of my surgeons, I don't know what the studies show. I could look that up, but I will tell you my 30 years of experience says most surgeons are going to tell their patients somewhere between 12 to 15 years. But I've got lots of patients that have had a total joint replacement 25 years ago, 20 years ago.
Well, yeah.
And they're fine.
Does it depend? I mean, because I would think like
activity level.
The hip is like generally a more robust joint than the knee.
Hips last longest.
Okay, yeah. So do the replacements are kind of the same
kind of in this
pattern?
order. Hips last longest, knees the second longest, and shoulders the third. Third longest.
So basically, the more range of motion that they have naturally is going to put more stress on that replacement. You think?
That's one of the factors, but more importantly, it's the design, the natural anatomical design of the joint and its surrounding support to start with. Yeah. The hip is bearing the most amount of weight, but it's also bearing the most amount of weight with the largest surface area.
Right.
So it can disperse that load and those forces over a larger surface area of contact. The knee is going to be the second heaviest weight-bearing joint, and it has a smaller surface area, and it gets more action when you think about it. It's got to go through, like you said, more range of motion. It's used more throughout the day.
Right.
And then the shoulder goes through a lot of range of motion, but it has a much lower load base, and it's not a weight-bearing joint. I mean, unless you walk on your hands.
Right.
Unless you're primal.
Well, and you think about like the hip joint is surrounded by the largest muscles of the body.
Right.
The
and
knees.
That's a big, stability.
Right.
The stability around the joint, and just, the hip joint is a socket joint The knee joint is a hinge joint, and the shoulder, we call it a socket, but it's not. It's more of like a cup and saucer.
Yeah.
It is really held together mostly not by its bony interface, but more importantly by the ligamentous, the capsule, and the muscular interface. All the tissues around it, what we call the active and passive stabilizers of the shoulder.
Right.
So let's talk a little bit about, those are the three common joints, the shoulder. Now, we see metacarpal, finger metacarpal head replacements. We see it in the feet. I've seen ankle replacements. I've seen, lots of different joints. Elbow replacements, those joints, the technology is just not very good. And I would recommend that kind of surgery for someone that just has no function.
Right.
The technology's good, but the lack of number of units out there and the lack of opportunity to look at failures and pluses and minuses over time in longitudinal studies is just it's not as robust in these other joints.
Sure. Yeah.
I would say the hip is the best joint to have to replace, then the knee, and then the shoulder last. So
yeah.
So we're going to talk a little bit about the types of joints that are being used, the types of materials that are being used to replace these joints. If you want to read a really good article about training and joint replacement, I got to give a shout out to my colleague, another doctor of physical therapy and professor. I think Delphi University is where he teaches, and he's also a practicing PT up in New York, and that's John Patrizio, Dr. John Patrizio. He wrote a great article for Starting Strength recently, I think back in May of this year, which is a great article regarding barbell training or resistance training and total joint replacement. So if you want to read in a nutshell what we're going to talk about today, you can read that article. He did a very good job at laying out a very simple approach to materials, surgical approaches, the recommendations for training, and et cetera, and then his recommendations. And he gives a synopsis at the end of the article, which is really good.
Yeah, so we'll link that in the show notes, but the article title is Training in the Artificial Joint by John
very good.
Patrizio.
Very good.
DPT. Yeah.
And it mostly covers resistance or barbell training, but the principles are universal when you read the article. So we're going to talk first about the materials. So the most common materials that are, let's just say this first. When I first started practicing, many orthopedic surgeons were putting new joints in using one of two fixation methods. Well, one of three, really. They were press fit, where they would just press them into the bone, and then the bone would grow into the implant. And so you had to be very careful with those, more careful with those joints earlier on in the rehabilitation post-op process because you're waiting for the purchase of the implant into the bone.
Okay, yeah.
There were cemented joints, and that cement is an acrylic cement that really came from the dental industry, or the technology came from the dental industry.
Kind of like
adapted.
JB Weld.
Yeah. Kind of. That's what happens when you make a podcast in the South.
Right.
Or with a blue-collar staff.
Right.
Kind of like super glue. Yeah. Kind of like JB Weld.
Duct tape.
Or is it kind of like that PVC glue that's got the purple?
Right.
You got the purple, and then you got the glue, and then you got to mix them together.
You got to mix them together, right? Yeah.
That's what JB Weld is.
Yeah.
I think JB Weld's freaking awesome, man.
Oh,
That
yeah.
stuff
So
it'll
that and WD-40. What can't you do?
WD-40. WD-40. That's the Irish version of the product that's sold over in the UK. No, but it's a water dispensing 40. Took 40 different formulas to get that product to go to market, and that's why it's called WD-40.
Interesting.
Yeah, it's pretty cool. You learn something here with an old guy. So different materials and different fixation methods. So we're talking about that. So we had press fit first, and then we had press fit and cemented. Mm-hmm. And now we kind of have cemented, and they still bang that implant or force that implant into the bone, and the bone still grows. The inner edges of the implant where it interfaces with the bone on the tibia and femur side in the knee, or in the hip joint on the femur and ilium, which would be the pelvis.
Yeah.
Okay.
Yeah.
And then also in the shoulder, it would be the scapula and the humeral head. Okay. But in all those areas, there is some bone growth into the protheses because they're porous. So if you look at the surface, the bone side surface of any of these prostheses, you'll see that it has a roughened texture to it, and that's because it's got a porous surface to allow the bone cells to grow in there, but it's also cemented too.
Yeah.
So that's the most common today. So that's why when we see these patients like post-op hips, post-op knees, they're up same day.
Yeah.
Surgery.
Yeah.
They're walking the same day, and within the next day, they're walking quite a bit. So that cement or fixation material cures very, very quickly. And it takes months thereafter for the bone to grow, but that happens over time.
So I'm thinking like, does that cement eventually dissolve within the body by the time that the bone has made that connection?
That's a really good question.
Or does it stay permanent?
I think it's a permanent fixation device, but
but
that's a really good question.
It provides,
I've never been asked that before. That'd be something I could do some research on.
Well, because I know that there are certain screws. Yeah. There are certain screws that can be used that will dissolve.
Absolutely. They become part of the bone basically. And they're either organic or they just naturally interface with the bone.
But the initial, basically, the purpose of that cementing is to provide the initial stability until you can allow that bone to grow.
And the person can get rolling a lot faster. And the faster we can get rolling within reason after the inflammatory process and the insult of surgery to fix this, the quicker we're going to get these people up on their feet.
Yeah.
And we get a whole montage of valuable things out of that. Number one, we get lower DVT rates, blood clots in the legs. We get more activity. We get increased bone healing. We get increased vascular healing. We get muscle activation around the joint. We get a better functional level, better ADL levels early in the process.
Well, I just think about what's the best way to grow additional bone tissues. Like eventually you're going to want to stress it and load it, when you can. So that makes sense.
Yeah, stress. Yeah, you want what we call osteoblastic activity. The osteoblasts are the bone cells that grow when there's trauma to the bone and it's repairing itself.
Yeah.
So it's building a new network or trabeculae of support. So with these joints, that's the normal fixation method. Now let's talk about materials. Mm-hmm. The most common three materials, and it varies based on where you are in the world, like 40% of all the joint replacements in Europe are ceramic on ceramic.
Okay.
And we see very few ceramic on ceramic implants here in the States, here in the U.S., but about 40% are ceramic on ceramic in the U.K. and in Europe. So a little difference there.
Yeah.
The most common implant that's used material-wise in the U.S. would be metal and polyethylene. So you've got a metal implant on one side, and then it sits on a polyethylene or plastic surface on the other side. And what that does, that gives you a nice gliding effect in the joint. And it gives you a surface that's similar to cartilage in regards to it's got some spring in it and some give to it.
Okay. Yeah.
So you've got metal and polyethylene. And the metals that they use are generally alloys like cobalt and chromium and complex metals that they use in these joints because of the strength and the weight. They're lighter,
right.
They're extremely, extremely strong. Like titanium and tungsten, these other metals that are really, really strong. Stainless steel's been used too in the past, but it's just heavier.
Sure.
A lot of hardware is still stainless steel in the body, but it's just heavier. And so there's a lot of metal in these applications. So they want to make sure that the weight is appropriate too.
Right. Now, do you have to worry about when you have a metal hip replacement or joint replacement, do you have to worry about the toxicity of some of the metals in the body?
We're going to talk about that.
Okay.
So we first got the ceramic joints. The beautiful thing about ceramic is, number one, it's organic. So you don't have to worry about those toxicity levels as much.
Yeah.
Number two, it's very, very hard, scratch resistant, and it's very, very durable. Okay. But we don't see that usage in the States as much. And we're the large prevalence of joints still, the material that's being used is metal with polyethylene.
Yeah.
So metal with a plastic insert to provide a weight-bearing surface. And then the last material would be metal on metal. And the beautiful thing about metal on metal is it's really, really strong. It has a longer life and a lower wear level per hours of usage than metal on polyethylene. The problem is toxicity levels potentially in the bloodstream and in the body due to the chromium and cobalt and other types of metals that are used. Now, here's the thing. Carcinogenic risk exposure from these metal ions currently remains kind of theoretical, and there's insufficient clinical follow-up for us to say that these metal on metal implants are causing cancer and other types of problems. Right. There are people, plain and simple, that don't do well with metal in their body.
Yeah. Yeah.
They have a allergenic reaction, or they have an allergy to, or their body just doesn't like metal. And in those cases, they might have a problem whether they had metal on metal or metal on polyethylene. I don't know. And so there are some people that can be a problem.
So is that part of the screening process if you are a candidate for a joint replacement? Is to kind of test your reactions to metals in the body, or is that?
No, they don't necessarily test your reaction, but when they do a medical history on you in screening, they're going to ask you, do you have any allergies, known allergies? Okay. And if you say, I don't do well with polyethylenes or plastics, and I have a plastic allergy, they need to ask you. They need to be a little bit more detailed about that and figure out whether or not your body would tolerate this.
Okay. Yeah.
I have seen patients that have had poor acceptance of the hardware and the biology in the biological interface, and they end up getting an infection, or they end up getting an inflammatory response, and then they end up getting an infection, and they end up having to open the joint up, lavage it, debride it, clean it out, wash it out, and I've actually seen them take the joint replacements out, the hardware out, pack it full of antibiotic beads, and the person would basically, what we have a flail joint. It's a non-usable joint for like 6 to 8 weeks.
Oh, yeah, yeah.
I mean, it doesn't have a joint. It's not in contact anymore.
Right.
It's just packed full of beads. So they have a leg that won't bend and move at the knee for a while because there's nothing to bend and move. There's no joint there. And then they take the antibiotic beads out, they lavage it and clean it again, they put the implant back in, maybe put a different type of implant, and they see how it goes from there.
Yeah. So that's something that's important when you're talking with your physician and consulting before surgery is if you know you have some allergies, that's something that needs to be brought up.
Especially when they relate to things like we're talking about. I mean, if you're allergic to peanut butter, that's a little bit different.
Oh, right.
But, So we talked about, we've got basically ceramic, metal on polyethylene, or metal on metal. In regards to which type of prosthesis is better for a high post-activity level, they all appear to be acceptable for resistance training and sporting activities and activities afterwards. Now, I say that with this caveat. Anytime you go pounding on a man-made surface in your body, you may be reducing its life or its long-term durability, just like any other machine parts.
Yeah.
And so you just have to remember that. Just like you did with your cartilage, if you had osteoarthritis, you may have had a metabolic disorder that caused the arthritis to die early. Caused the cartilage to die early, or you might have just had wear and tear over time. You might have been a high-level athlete. There's a lot of things, trauma to the joint to consider here. But no matter what, you just have to think about the fact that what is your activity level afterwards. If I was going to have a replacement right now, I'd probably have metal on polyethylene, because I think the science is the best there in regards to the outcomes and the usage of the joint and what I would want to use it for afterwards.
Yeah.
We're going to talk a little bit about the procedures now that relate to these joints, and we're going to talk about the hip first. There's two primary approaches to the hip. There's the posterior lateral approach and the anterior approach. Anterior means from the front. Posterior lateral means from the back and the side. It's a little bit to the back and side.
Yeah.
Okay.
Through the glutes.
Yep. They separate the gluteus maximus, separate the fibers. They don't cut them. They separate them. And there's a difference there. I mean, it's an important difference. Both of those approaches appear to have, and this is the important thing to get here, the same long-term outcome as one another. So the posterior lateral approach doesn't appear to be better than the anterior, and the anterior not better than the posterior lateral approach. Now, some of that may also be due to the population that we're doing these joints on, the lack of activity level to start with, and the lack of activity level afterwards. So they're really not trying to stress it early enough to really test which method was better or not.
Yeah, because you said long term, right? But there are some differences in the short term after the surgery between the two approaches.
Limitations,
right?
the limitations and precautions. So the posterior lateral approach. So in that approach, the one primary precaution after surgery, and every surgeon has different recommendations, but the general recommendations I've seen over the years are this: you have to avoid hip flexion beyond 90 degrees, adduction, which is bringing the leg towards the midline, okay, like crossing your legs, beyond neutral, which would be just straight, okay, And then internal rotation, which would be, if you were sitting, it would be taking your foot and reaching it out sideways without moving the rest of your leg. So it'd be rotating it internally, okay? Like if you were knock-kneed, okay?
Right.
So you have to avoid internal rotation. You have to avoid flexion beyond 90 degrees and adduction beyond neutral for about 6 weeks, okay? Now, especially during active range of motion. Weight bearing, I've seen surgeons say up to 8 to 12 weeks. Okay, so if you're doing resistance training or weight bearing or those types of things, up to 8 to 12 weeks, like you go to sit to stands or squats or deadlifts or anything, you have to be very careful because you could dislocate. What happens is because of the approach, where they go into the joint and through the capsule and the muscles that they cut. When they go in, they cut the deep external rotators, and sometimes they sew those back on and sometimes they don't. Okay, so you just might look at the op report and see if the surgeon did that, because that's important in regards to stability of the hip and how early you could start someone to squat.
Right. That stuff's got to heal up and provide support to the joint before you start loading it.
Right.
So now the joint is kind of surrounded by a sheath of connective tissue, right? The joint capsule that's separate from the muscle tissue. Right. Yeah. So are they always, they've got to cut through that as well. So that's something else that needs to heal as well.
Yeah, they pop
separate from the muscle tissue.
Yeah, when this is all done, it's like popping a chicken bone. I mean, they pop this joint out backwards.
Yeah.
Posterior lateral. They pop the femoral head out so that they can replace the femoral head, and then they also get access to the acetabulum so that they can do the acetabulary replacement. That's where the polyethylene goes in, is in the acetabulum, and the femoral head is the metal surfacing.
Yeah. So they got the head, and then the socket is the acetabulum.
Right.
The head
exactly.
Exactly.
Right. So when they do that, they do it posterior lateral. So that's where the weakness of the capsule and the weakness of the joint is. So you could see that all those things like internal rotation, adduction, crossing the leg, and then flexion past 90 basically pushes that bone, that head, back towards where the incision is and the instability is. And so general thumb I have with my clients is we're very careful for the first 6 weeks. Okay, we avoid all those positions, and then we gradually will load up over time in a very slow progression over time. But for that first 6 to 8 weeks, we're really careful, and we basically do body weight work.
Yeah.
Okay, so the other approach is an anterior approach, and that approach, they go through the front of the joint. Basically, they go usually between the sartorius and the gluteus medius. That's the general approach, is in that region. There's a little triangle right there. They go through there. Now, the beauty of that approach is that you can start those activities like we're talking about much earlier. Here's the problem with looking at outcome studies with this population. Most of these people are not barbell training.
Right.
Most of these people are not lifting before surgery. They've long since left that activity in their life.
Yeah.
And so when you do a study with these people, it's hard to know, well, how well are they able to squat, and how well are they able to deadlift after hip replacement surgery? Well, they're not doing that.
Right. If
they weren't doing it before, they're not doing it after.
Yeah.
So it's hard to study. But it would just seem, and my professional experience would tell you this, I have had clients that have gone back to lifting. They lifted before and they lifted after a hip replacement or a knee replacement. And in the hip, the anterior approach allows a much quicker return to regular activity. We have to avoid some other things like extension, extension beyond neutral. We have to avoid some other things.
Sure.
And so, but you can get back to activity much quicker. But again, we talked about the idea that a lot of these people don't do that anyway.
Right.
So in the long term, the studies appear to be about the same in regards to the outcomes and the quality of life after a total hip replacement with either approach.
Yeah.
Now, in the knee, there's pretty much one approach. It's anterior. There's not a lot of difference there. I mean, I have seen some guys go a little bit more medially, but anterior is the approach. It doesn't really affect the joint as much. And we get that joint rocking and rolling really quick anyway. I have never in 30 years had a knee dislocate after a total knee replacement.
Okay.
I have seen a hip dislocation.
Sure.
But I've never seen a knee dislocation. And in the shoulder, it's right over it's the superior and anterior approach. So they just make a large incision right there in the front in a superior anterior direction. And it's a large incision. And so there are some limitations there, but they're basically the same. We call it avoiding the Aber position, which is abduction, external rotation. So we want to avoid being right here.
The cactus pose.
Yep,
Right.
Yep. And we want to avoid being right there.
Yeah.
And overhead flexion is limited for a while, and in-range extension is limited, in-range abduction. So generally 6 to 8 weeks, and then we get those people rocking and rolling. So, but the approach in the hip is probably the most important consideration in regards to how quickly you can get back to activities, especially if you're a lifter or you do some type of fitness activity afterwards.
Now, one more question about the approach for the hip. How much does surgeon preference play into this? So if you have a surgeon that has done a lot of posterior approches,
that's what they're going to do.
Okay, yeah. So
you're not going to talk them into doing an anterior approach if they feel really comfortable with the posterior lateral approach, and vice versa.
And would it be given the fact that long-term outcomes seem to be the same for both approaches? If you've got a good surgeon that you like, then maybe just let them go with the approach that they're comfortable with.
Yeah,
right?
you're really not going to have purview on that decision.
Well, yeah, it's not like it's your decision.
If the guy says, I'm going to do a posterior lateral approach, and you say, well, I don't want that, I want an anterior approach, he's most likely going to say, go find another surgeon. That's what you're going to do. Yeah, I want the surgeon to do the thing that he or she thinks they can fix it best with.
Sure, yeah.
What they feel most comfortable with.
Yeah.
Now, the other thing to consider here is, we talked about procedures a little bit, approaches, we've talked about implant materials, but let's also talk about an implant that's less commonly done, but appears to have pretty good data in the literature. I personally don't like this implant. I have not seen in a clinical practical setting that this implant is as well tolerated long-term for my client base, but that's contrary to what the data says. So it may be that I have not seen enough volume, enough cohorts. I've not seen enough data points in this population, and that is what we call a unicompartmental implant in the knee. So instead of replacing the whole femoral end, the condyles of the femur surfaces and the tibia, they might just replace the medial portion of the condyle, the medial condyle surface, and then they put a little polyethylene and metal implant on the medial side of the tibia, down in the fossa.
Yeah.
And so I don't like the idea that you have biological tissue interfacing in the same weight-bearing setting as artificial tissue or artificial materials. I know that they've tried to, as best possible, make those materials mirror each other, but I just don't like that. I either like it to be all different or all the same.
Yeah, I guess it basically you've got inert tissue on one end, and you've got dynamic biological tissue that's
correct.
Yeah, it's
correct.
It's organic. It's going to change.
Yeah, and I think basically what people are doing there is they're buying time.
Yeah,
because I think eventually what's going to happen is the biological interface is going to fail eventually, and the implanted surface is not going to fail. Well, they just take that out, and then what they do is they end up putting a total joint.
Now, I've heard about resurfacing of the hip of the acetabulum as well. Is that something that will sometimes be done? Is actually replacing the surface of the acetabulum?
Yeah, I mean, there's several surgeries that are kind of stopgap surgeries prior
Same
to
kind of idea,
considering, and some of that's client selection criteria. How old is the client? What do they want to go back to do? If someone's 45 years old and they got a blown hip, and you could do a resurfacing technique, that might be a better option, or a microfracture technique. That might be a better option than going ahead and replacing the joint. But it's definitely not the solution.
Right.
It's a short-term solution to a very long-term problem. That person's going to have a total hip replacement.
Yeah.
Same with the knee. The technology's not there, and we ought to have I've got a friend that's an expert in this area with cartilage implants and things like that. But I think that best case scenario here, if you have a joint that's that bad, you're probably going to have a total knee or a total hip within the next 2 or 3 years anyway.
Sure, yeah.
So, it's a matter of it's just a matter of time. So in the knee, we're seeing some cartilage implants that seem to have better outcomes. I'm seeing that clinically. I've got 2 patients right now that had cartilage replacements. So what they did was they took cartilage cells out of their knee, they grew it in a petri dish basically, and then once they got a big enough piece of cartilage to reimplant in the joint, they basically go in, they clean out the crater, they plug this in, and then it grows back into the existing live cartilage.
Yeah, that's so interesting. That
Yeah, it really is. I mean,
Crazy.
I think probably within maybe not my lifetime, but yours, maybe in my lifetime, we'll have total cartilage replacement.
Yeah.
Replacements being done.
Now, you've mentioned this in a previous show, though. One condition here is you've got to have some cartilage to start with.
Yeah, and 9 times out of 10, there's a place on the knee where they can pull some cartilage out.
Yeah.
That's not weight bearing. There's part of the femoral condyles where there's very little to no weight bearing surface.
Yeah.
It's minimal weight bearing. And so they probably got some good cartilage in there. It doesn't take a very large sample to grow cartilage. So they can pull that out, grow it in the lab, stick it back in later.
Okay.
And they can also use an allograft where they get it from a cadaver too and put it in. But so yeah, I mean, these unicompartmental replacements are popular for someone that's very active and much younger and really has a good rest of the joint.
Yeah.
So you could replace the medial side or the lateral side and sometimes also in joint replacements, they'll replace the patellar, the back surfacing, the posterior surface of the patellar cartilage too. So they'll put a little button on the back there for the patella too.
Yeah.
So unicompartmentals are another thing to consider. If it were my knee and my knee was just trashed, I think that is a surgeon patient discussion that has to be had, and the patient has to rely on the surgeon's knowledge of and experience how much life does this joint have left in it if we go unicompartmental, or if we go total joint, it's the life of the total joint.
Right. Yeah, we've had this same discussion here in the show with one of our gym members here, JoJo. She's been kind of doing that same calculus. She's well, I won't say how old she is exactly, but we'll say somewhere between her late 40s and mid 50s.
Yes. Yeah.
And
and somewhere between 45 and 55, and split the difference equally.
Somewhere like right in the exact middle between those points. Somewhere. Mathematically
speaking.
But yeah, so she's doing kind of the same calculus. It's like, we know she's got a damaged knee. She's had injuries. She's been active her whole life, right? And it's kind of been a game that you and her have been working out of like, let's train around this as long as we can, because the question is, when you do get the surgery and you do the replacement, like how you don't want to do it again. So let's try to push it out as long as you can.
Right.
Yeah.
Yeah. And I think that, that the most important thing to consider here is it's all that there's data that we can look at that's hard, good data, but then there's also physician experience and patient need and patient outcomes, the goals and the outcomes of the patient.
Yeah.
And the key is try to match all those things together.
Right.
The doctor's experience, the doctor's comfort with a particular procedure, what he or she has had the best success with their client base, and then the patient's outcomes and goals, and try to match those two things together.
And I think, talking to JoJo here in the show and in person, like she has changed her outlook on what she wants out of fitness. So she may not be pounding the box jumps in Metcons 4 days a week anymore.
No running, right.
But she's been able to find a comfortable level of activity for what she wants and her goals. But she's also had to compromise from where she was a few years ago.
Yeah, and I'll tell you to be honest with you, she can pretty much squat or deadlift, leg press in the way that we do it, weighted step-ups, lunges in a certain way. She can do all those things and have minimal knee pain just through modifying her programming.
Yeah.
But we did have to get rid of some of the ballistic pounding activities that just, really anger her joints. So, So, all right. So let's talk about how does total joint replacement impact training? It just matters.
Yeah, right.
But in general, here's the rule. Here are some rules or guidelines that we can follow with a client or a person who's had a total joint. So if you've had a total joint replacement or you're considering one, here are some things to think about. If you have a total hip or total knee, I'm going to talk about total hips and total knees. Total shoulders we're generally much more conservative with because there's much less bone to stick the parts on. And it's going to be more restrictive over time. But And there's what's called a reverse total shoulder too. We're not going to get into that. We could do a separate episode just on the shoulder. But I would say this. I have seen total shoulder replacements go back to lifting and doing overhead presses and doing bench press. And a lot of times it's a restricted range of motion bench press, but I have seen them go back and they deadlift and they squat, and you can get back to a lot of different activities. Okay. Let's talk about knees and hips.
Yep.
In general, I don't allow any of my barbell clients to actually lift for 6 to 8 weeks after surgery, merely for the precautionary period to allow ligaments to get stiff again, to allow muscles to heal, to allow the joint incisions to heal, and to make sure that we have good, stable joints. And also, and a lot of people don't consider this because they don't understand this, that is, we want to make sure that there's no migration or movement of the implant on the bony surface.
Right.
And so
right.
the little bit longer time to allow that bone to grow into the implant, vice versa, and for the cement to cure, all those things that create that strong biological metal or strong biological artificial interface, it's important because you get a tiny bit of microscopic movement in those joints, in those implants, and you got a painful joint.
Yeah.
Okay. Really painful joint. It's the same that with lumbar fusions. It's the same with any hardware put into the body. There is a period where we have to be careful, and we just need to make sure that we protect the integrity of the purchase of those parts in the body.
Right, right.
So it may seem really restrictive, and it may seem that we don't want to load them again, but there is a greater good here. Okay?
Right, right. Listen to your doctors.
Yeah. In this area, I think 6 to 8 weeks is a generally good time frame. Now that doesn't mean that they're not going to be doing leg lifts and isometrics and walking, and they're going to be doing sit to stands. They're going to be able to do all the stretching in the world that we want to do within the precautionary ranges of motion based on the approach of the hip. The knee is not as important. We want to get knee range of motion immediately, so we want to get full extension and the flexion that is available based on the implant. There are some implants that allow more flexion than others.
Yeah.
But in general, my rule of thumb is I like to get 120 degrees of flexion. If a person can get 120 degrees of flexion, they can squat to the parallel.
Yeah,
okay?
I was about to say that's kind of like hip crease below kneecap kind of.
Yeah, it's about
area.
It's about that position. And so 120 degrees is good. I've got lots of patients that only end up with 115, and I've got patients that end up with 130.
That'd be awesome if it could just naturally stop just right at depth. You never have to worry about squatting too deep.
Like you put a mechanical block there.
Yeah.
And some of the knees are designed to lock at a certain range of motion. There are to stabilize the joint to ensure that the joint doesn't dislocate.
Yeah.
But like I said, I've never seen that happen with a knee replacement in my practice, at least, or in training. So we've got that 6 to 8 week of precautionary period. Now, when we start back up, I like to start after we do body weight work and we start actually loading the joint. I like to start partial range of motion activities. So if I'm going to deadlift, I prefer rack pulls over RDLs because there is a set limit at the bottom of the range of motion, and I can set the range to have the reps be the same every single time.
Right.
If it's a posterior lateral approach, I progress a little bit slower. If it's an anterior approach, we rock and roll. Okay, we do a linear progression.
Yeah.
I have a client right now, and he's 67, and he had both of his hips replaced earlier in the year. I think one in January and one maybe in March. And they did an anterior approach on both of these. It's kind of an anterior lateral approach this doctor does. Did a fantastic job on him. He is squatting in the 130s to a box right now. And he deadlifted 185 the other day for 5.
Awesome.
And that's a full deadlift.
Yeah.
Okay. So, he's crushing it, He's doing very well. But we did this process with him. We basically started him on protected range of motion, working from the top down. And in the squat, it's the same way. We would squat to a box and have a limited range of motion squat, staying out of hip past 90 degrees on a posterior lateral approach.
Did you start above parallel for a while and then move it down?
Yeah.
Okay.
We start above parallel and work our way down over weeks.
Okay.
Probably for most individuals within 14 to 16 weeks, we are squatting close to the parallel.
Okay. Yeah.
But, a lot of people are like, wow, it took a long time. It took 4 months. I'm like, a lot of these people have never lifted before anyway.
Right. Yeah.
I mean, we're not talking about, on the average, most of these people never lifted barbells anyway.
Right.
So if I'm doing a kettlebell squat or a front squat or a goblet squat or something like that, then I get it. But at the same time, now what I don't limit would be the upper body lifts, other than we want to make sure that we're not putting the hip joint in a position that could cause it to be at risk.
Yeah, so I think immediately I'm thinking of like a big hip drive on like a press.
That's right, especially with an anterior approach.
Right, yeah, you don't want that.
Right, so it's a strict press.
Yeah.
On the bench press, we might have the feet up on some plates where the hip is not as extended as it would be. On the squat, one thing we're really going to be careful of on the squat and deadlift with this posterior lateral hip approach is we're going to make sure that they stay knees out, even on the deadlift, okay? Because we don't want them to be forced into adduction or like knock-kneed. They get knee collapse.
That's that internal rotation,
under load, and that puts that hip under a tremendous amount of stress.
Yeah.
And we want to be careful with that for months afterwards, okay? So the general rule of thumbs that I follow are protected range of motion when we start loading, and we start loading with external loads at around 6 to 8 weeks for closed kinetic chain, which would be weight-bearing type exercises, okay? That'd be squats, deadlifts, step-ups, those kind of weighted step-ups. Now, I'm doing body weight work way before then.
Right.
In range of motion, protected range of motions, we're doing hip bridges on the mat. We're doing leg lifts. We're walking, we're doing the bike, lots of range of motion to get blood flow in those areas, heal those tissues early on, and get adaptive scarring to be flexible and mobile. And then we start doing protected range of motion loading at about that 6 to 8 week mark. And, within 3 to 4 months, these people are rocking and rolling. I mean, we're like with my one client right now, he had already rehabbed a lot. His first hip replacement, and then 2.5 months later, it might be a little longer, I can't remember exactly, might have been 3 months, he had his second hip replacement. He was already barbell training again.
Right.
So, and then we had the second hip replacement, we had to start over.
Yeah, and I think about like in the big picture, right? Is it really that big a deal to take 3 or 4 months to load? If that's what it takes for you, for yours, like what's the rush, right? It's not like you're a pro running back trying to get back and, get that next contract or something. I don't even know if you could after a hip replacement, but it's not like you're pro athlete, right?
Correct.
So what's the big rush? You've got the rest of your life to train.
Here's where I agree with that, but here's where that variable changes a little bit.
Yeah.
There's a lot of data to show that people over the age of 65 to 70, the quicker you can get them moving, the lower the mortality rate.
Yeah.
We know that to be true with things like hip fractures and femur fractures. The mortality rate goes through the roof when those types of fractures occur over the age of 65 to 70 because they become inactive, they throw a clot, they have a heart attack, they have a stroke. All the debilitating factors that go along with recumbency or being sedentary. So with my older client base, I like to get those folks rolling.
Yes.
And they're doing things that most people think they shouldn't be doing, but they're all protected range of motion. They're all appropriate based on the surgical intervention, the procedure performed, and the material that they have. Now, let's just go through a general summary of the current evidence here. And I got to give John Patrizio credit here because I'm basically going to read from his list because I love this list. He basically gives the following recommendations. When we talk about weight-bearing surface, what's the optimum weight-bearing surface? We don't know yet. There's not been enough studies. But if I were going to have an implant done right now, I would probably say metal and polyethylene. Okay, that's just my own personal opinion. Secondly, hip resurfacing and unicompartmental knee replacements both appear to be safe and have pretty good outcomes in the literature. Even though I don't like the unicompartmentals, they seem to do fairly well in the literature. Now, I think in those cases, subject selection is key. If you choose the wrong patient for one of these two procedures, you get a poor outcome.
Yeah.
If they've got too much damage in the other compartment of the joint and they're trying to salvage doing a total and they do a uni Instead, that person within a year is going to be crying.
Yeah.
So, I think patient selection there is key. And I think if you're going to have one of those procedures done, like a resurfacing or a unicompartmental procedure, you need to have a long conversation with your doctor as to why they're choosing that, why they would say, yeah, I think this will work for you. What's their rationale?
Right.
Reverse total shoulders have increased over time. We have a lot more of those being done, and they generally do a reverse total shoulder when the rotator cuff and the stabilizers, the small stabilizing musculature, the cuff muscles are just gone. Okay.
Yeah.
And so there's no way to keep it together. So what they do is they actually use a ball where the socket is and a socket where the ball was. They reverse it.
Okay. Yeah.
Okay.
Yeah.
And so then it becomes a more stable joint. But the complication rate is higher for that type of procedure too. So that's just something to consider. But I have actually seen quite a few reverses, and they have done very well. Now, I've been seeing reverses for about 10 years now, probably. So that's still not a long time to look at, whether that patient's going to need to come back. A lot of those patients have probably passed away since then because they were much older clients to start with. Total joint replacements have shown a negligible impact to post-op physical activity. And that means that a return to more strenuous activity appears to be related to more the patient's own motivation than the actual discomfort or type of implant. So let me put it this way. People that are inactive before are inactive afterwards. People that are active before are active afterwards.
Who would have thunk? Right.
Welcome to human nature. So I would say if you're thinking, man, I'm going to get a total hip replacement, I'm going to get after it afterwards. Well, are you getting after it now in some form or fashion? And so your activity level and motivation before will drive your outcomes after.
A wise man once said, an object at rest tends to stay at rest.
Exactly.
And an object in motion tends to stay in motion.
Exactly. It's called physics. Science. And the last thing is that there's really not enough research to say what the impact of resistance training has on the activity levels of individuals and implants long term. Okay? But I would just say this. The science is pretty clear here on what resistance training does to the rest of the body and what it does to normal human tissue and what it does for rehabilitation. So we just don't have studies to prove it. But just because we don't have studies to prove it yet doesn't mean that it's not proved.
That's right. Yeah.
Anecdotally, experientially, and observationally, my 30 years says if you want to have a better quality of life, you better be lifting weights and you better be in some type of fitness program.
That's right. Yeah. Yeah. We see this all the time with strength training and studies. Like,
yes.
Yeah.
Yes.
Just because we don't have a double-blind study doesn't mean it don't work.
So let's just wrap this up and say it this way. If you are a listener out there and you're trying to consider whether or not you're going to have a joint replacement, number one, speak to your surgeon and physician. Counsel with them. Number two, if you have a really good doctor of physical therapy in your market, meet with them prior to having the replacement. Talk to someone with a lot of experience and how their clients did.
Yeah.
Number three, the type of surfacing right now in regards to resistance training and general fitness training doesn't necessarily seem to matter right now from the data that we have. But if I were going to have a joint done, I would have metal on polyethylene right now until new technologies come out or new data comes out. Number four, you've got to follow the precautions on these joint replacements for stability and protection of the joint. Generally, 6 to 8 weeks is a minimum for some of these procedures. The knee, we can be much more aggressive with. The hip, we really have to follow the precautions and make sure that we're careful with those movements that we talked about. And then last but not least, train, man. Train. Lifting. I don't have a single client that is post-op TKR, total knee replacement, or total joint arthroplasty, any joint, that I wouldn't recommend a moderate lifting program for in the appropriate time frame post-op.
Yeah, I think if I had a hip replacement tomorrow, in the first 6 weeks, I'd try to get my biceps as big as I could. I'd just be doing curls.
Yeah. And you know what? You'd be doing some conditioning. I find it funny when people have injuries or they have joint replacements or surgeries. Their life just, they say, well, I couldn't work out for 3 months because I had a hip replacement. And I'm like, what? I've got a video of me, and I'm not tooting my horn. I'm just saying it's a mentality we develop. I've got a video of me 7 days post-op reconstruction, left shoulder. I'm in what we call an abductor immobilizer.
Yeah.
That holds you away from the body. I had my cuff. I had 4 anchors put in my cuff. Had my joint completely cleaned out, reconstructed. And I'm 7 days post-op doing arm curls and like a thruster motion with the off arm. I'm doing the assault bike. I'm doing all my rehab exercises. I'm doing one-handed deadlifts. I'm doing walking lunges. I mean, your fitness training doesn't have to stop. Be careful and be cautious about what you're doing because your balance might be off and some other things. But you can work other parts of your body, people.
That's right.
And you can stay shape. People say, well, ever since I had this injury, I gained 30 pounds. I'm like, well, did you reduce your food intake?
Right. Yeah.
No. Well, your activity level went through the tank. Don't blame the surgery.
Right.
Blame your pie hole. Yeah. Stop feeding your face. And that's for another episode.
Yeah.
So, all right, guys. Well, thanks for joining the 40 Fit Radio and thanks for joining the 40 Fit Nation today. If you want to hook up with us online, you can go to 40fit.com. You can email us, info@40fit.com. You can find us on Instagram @40FitRadio. Trent and I we've said it 1,000 times, our own Instagrams. You can find us. And then you can go to 40 Fit Nation on Facebook. We love having you guys. Thanks for joining us today and have a safe and good rest of the week. Bye, guys.
Adios.